Hi there, Dr. Yang from Pancreatic and Biliary Surgery. In this lecture, we will talk about the disease of pancreas. The contents include the anatomy, the physiology, and the inflammatory disease, pancreatitis, and the neoplasms, benign and malignant. First, structure. The pancreas lies in the retroperitoneum, divided into 4 portions: the head, neck, body, and the tail. The head lies to the right of midline, with the C-loop of the duodenum, and anterior to the vena cava at the confluence of the renal vein. The acinic process extends from the head of the pancreas behind the superior mesenteric vein, SMV, and terminates to the superior mesenteric artery, SMA. The neck is the short segment of the pancreas that overlies to the SMV. The body and the tail of the pancreas then extend across the midline, terminating within the splenic hilum. Vessels supply. First, arterial blood supply. The pancreas is supplied by a complex arterial network arising from the celiac trunk and SMA. The head and acinic process are supplied by the anterior and posterior pancreatical duodenal artery, which arise from the hepatic artery via the GDA, gastroduodenal artery, superiorly, and the SMA inferiorly. The neck, body, and tail receives arterial supply from the splenic artery system. Then, venous drainage. The venous drainage mimics the arterial supply, with blood flow from the head of the pancreas draining into the anterior and the posterior pancreatical duodenal vein. Here are the imaging of the structure and the vessels. On the left side, we can see the vein system, and on the right, we can see the adjacent structure, organs, and the vessels. We can see the relationship. Physiology of pancreas. The human pancreas is a complex organ with endocrine and exocrine functions. It may mainly composed of acinar cells and islet cells. The acinar cells synthesize many enzymes and digest food proteins. In addition to the enzyme production, the acinar cells also produce pancreatic amylase and lipase. The acinar cells can be divided into beta cells, alpha cells, delta cells, and PP cells. The beta cell can produce insulin, while the alpha cell can produce glucagon. The delta cell can produce somatostatin, while PP cell can produce pancreatic polypeptide. We will talk about acute pancreatitis. Acute pancreatitis, we usually call that AP shortly. AP is the final result of abnormal pancreatic enzyme activation inside acinar cells. Well, intra-acinar pancreatic enzyme activation induces autodigestion of normal pancreatic parenchyma. In response to this initial insult, acinar cells can release pro-inflammatory cytokines. While the inflammatory cascade is a self-limited in about 80%, even 90% of the cases. However, in the remaining cases, about 10%, the circle of pancreatic injury and systemic inflammatory reaction persists. Physiology. The most common causes is biliary or gallstone pancreatitis. In obstructive theory, pancreatic injury is the result of excessive pressure inside the pancreatic duct. This increased intraductal pressure and it's a result of secretion of pancreatic juice in the presence of pancreatic duct obstruction. The reflex theory proposes that stone become impacted on the ampulla of fata and form a common channel that allows a bile salt reflux into the pancreas. The second cause, alcoholic-induced injury. Alcohol consumption, excessive alcohol consumption, is the second most common cause of AP worldwide. It accounts for about 1/3 of the cases and is more prevalent in young men than in women. The third one is metabolic factor. Hypertriglyceridemia and hypercalcemia can also lead to pancreatic damage. Direct pancreatic injury can be induced by triglyceride metabolisms, and it should be suspected in the patient with hypertriglyceridemia. Clinical manifestation. For AP patient, the patient may have epigastric or periumbilical area pain while the pain is constant, usually radiates to the back. The patient may have dehydration, tachycardia, hypertension. For the severe case, may have mental status changes. In the physical examination, the abdominal findings may vary according to the severity of the disease. For severe case, we can see the two pictures. There are Greater sign and the Cullen sign. We can see the ecchymosis at flank and the periumbilical area. They both indicate retroperitoneal bleeding. Usually, the two signs usually appear in the severe acute pancreatitis patient. Diagnosis. Diagnosis of AP usually based on clinical findings and pancreatic enzymes level and typical imaging, at least two of them. We will talk about the pancreatic enzymes, amylase and lipase. At least threefold elevation of amylase and all lipase levels confirms the diagnosis. Well, the serum half-life of amylase is shorter than that of lipase. So over 24 to 48 hours after the onset, determination of lipase level is more sensitive. Sometimes serum amylase level can be elevated in a number of conditions, like peptic ulcer disease, mesenteric ischemia, or some other disease.